Welcome to this module in which you will be provided with a trauma overview. Upon completion of this module, you should be able to define kinematics of trauma, discuss various traumatic injury patterns and their predictability, discuss specific injuries related to multi-system trauma, discuss identification and categorization of trauma patients, discuss the golden hour, golden period, describe key components of the trauma patient assessment, list significant mechanisms of injury, discuss trauma scoring, discuss management of the trauma patient, differentiate between injury patterns seen in adults and pediatrics, describe the injury patterns and causes of trauma in geriatric patients, discuss risk factors that make geriatric patients prone to injuries due to falls, explain the importance of fall prevention in geriatric patients, and appreciate the importance of recognizing significant mechanisms of injury early in the assessment process. Kinematics of trauma is considered to be the transfer or conversion of energy that results in a traumatic injury. Injuries are the leading cause of death and disability among children and young adults, and studying kinematics introduces the basic physical concepts that dictate how injuries occur and the effect on the human body. The use of kinematics also enables the EMT to approximate the forces involved in traumatic injuries and use that information during the patient assessment process. Where trauma is concerned, EMS providers must use their magic crystal ball, so to speak, to try and predict injury patterns based upon the mechanism of injury and the story gathered from the patient and witnesses. When dealing with any traumatic injury, one should always maintain a high level of suspicion. Stated another way, maintain heightened awareness of and concern for potentially serious underlying and unseen injuries based upon the mechanism and potential forces involved in the traumatic event. Anticipate internal injuries that cannot be seen by visual inspection only and be prepared to treat them if suspected. It is not entirely uncommon for a patient to not have pain like one would expect given a significant injury due to the body's production of adrenaline and endorphins after the incident, and many experienced providers have stories about patients denying any complaints at the scene of a car accident to only discover later that they have significant injuries. In many of these cases, patients ultimately avoided detrimental outcomes because the EMS crew investigated the mechanism of injury, maintained a high level of suspicion, and then convinced the patient to allow EMS to treat and transport based upon the mechanism of injury as opposed to the patient's actual complaints at the time. Simply stated, treating based on the mechanism of injury can have a significant effect on the patient's eventual outcome after a traumatic injury event. For those of you who remember the law of conservation of energy from your high school physics class, remember that energy cannot be created or destroyed. It can only be converted or transformed. Windmills, for instance, convert the energy from the wind into electrical energy. The windmills do not create energy out of nothing. Rather, they transform the energy inherent from the moving of the air to a different form of energy. This principle is important for treating victims of trauma. The energy from the traumatic event is absorbed into and transformed by the human body. This transfer of energy into the body can result in significant damage to body structures and organs. When treating a traumatic injury patient, the EMT must keep this principle in mind to aid in developing a treatment plan for the patient. To continue our discussion on the kinematics of trauma, it is important to define some additional terms. Work is defined as some type of force, a push, bend, pull, compression, etc., acting over a distance. Kinetic energy is the energy inherent within a moving object. It is the function of mass and velocity. As the mass or speed of an object increases, so too does the amount of kinetic energy within the object. Of these two factors, velocity is of paramount importance. Kinetic energy is defined by the formula 1/2 the mass times velocity squared. For those of you who remember your math from high school, squaring a variable results in what is known as exponential growth. Doubling the speed results in 4 times the energy. Increase the speed by 10 times and the energy increases by 100 times. This is why the speed of a bat is more important than the weight when discussing home runs. The faster the bat, the more energy imparted into the ball. Increasing the weight of the bat does not have as substantial an impact on the ball as does the speed of the swing. Another example is a bullet fired from a gun. Throw a bullet at somebody, say at 40 miles an hour, and they may not even feel it. Fire it from a gun at over 650 miles an hour, however, and the bullet travels with much more energy, resulting in the potential for significant trauma. In a car accident, the faster the vehicles are moving, the greater the potential for significant trauma given significant energy transfer. With that being said, do not discredit the mass of an object either. Being hit by a Nerf football at 25 miles per hour is very different than being hit by a freight train traveling the same speed. The velocity of an object is very important, but so too is the mass of the object. Potential energy is stored energy, the amount of energy available in a stationary object. In most instances, potential energy is used to determine the theoretical energy of a falling object. Thus, it is commonly the product of mass, weight, force of gravity, and height above the Earth. With that being said, there are other forms of potential energy and mechanisms for storing such energy, such as springs, pendulums, and so on. From an EMS perspective, potential energies are always a consideration at the scene of a car accident. Airbag systems contain potential energy. Compressed shocks or struts, especially if part of a bumper system or door hatch system, contain potential energy that can be harmful if released suddenly. With these terms in mind, traumatic injury occurs to the human body when its tissues, organs, or systems are exposed to forces beyond their tolerance. If the body is not able to safely absorb or diffuse incoming energy, traumatic injury will result. While this little physics review is very important, do not worry too much if physics was never your strong suit. As an EMT, you will never have to pull out a scientific calculator on a call to determine the forces applied to a body during a traumatic injury incident. It is important, however, for an EMT to recognize and identify various mechanisms of injury and determine whether or not injuries are likely or could have been sustained as a result. Thus, a basic understanding as to forces and energy is necessary to anticipate potential injuries given a traumatic incident. The way this all applies is that objects, when stopping, need to absorb the kinetic energy associated with that motion. Thus, when a car stops, the brakes must absorb the kinetic energy of the car. If the stop is sudden, maybe due to striking another object, such as a tree or another car, the brakes do not absorb any energy. Instead, the vehicle's frame and body begin to absorb energy. Because the kinetic energy is transferred throughout the car, the human body within the vehicle also absorbs energy. There is also subsequent movement within the vehicle compartment that contributes to injuries. The person inside a car traveling at 60 miles per hour is also traveling at 60 miles per hour within the vehicle. If the vehicle stops suddenly, the objects within the car, including the passengers, are still traveling at 60 miles per hour until something stops them. That something may be a seatbelt, an airbag, the steering wheel, or maybe the windshield. If the person is ejected because he or she was not wearing a seatbelt, the object stopping them may be the road, a tree, the ditch, etc. Once the human body decelerates, the organs within the body are still traveling at 60 miles per hour within the body cavities until they are stopped by other body structures. Given a significant mechanism of injury, internal organs may be damaged, bones can break, and other injuries not compatible with life may occur. Continuing our definitions, potential energy is the product of mass, weight, force of gravity, and height. The potential energy of this worker on a scaffold is his weight, his height above the ground, and the force of gravity. If he falls, converting potential energy into kinetic energy, and hits the ground, the energy from the fall will be absorbed by the body. Depending on the height of the fall and the way in which the worker lands, the resulting trauma can be minimal, fatal, or somewhere in between. Delving a little deeper into physics, energy, and forces, we need to take some time to discuss Isaac Newton's 3 laws of motion. The first law of motion is the law of inertia. An object at rest tends to stay at rest, and objects in motion tend to stay in motion unless they are acted upon by an outside force. The applicability of this law to EMS pertains predominantly to blunt force and deceleration injuries. Going back to the person traveling in a car at 60 miles per hour, if the car suddenly stops, the body wants to continue moving unless an outside force stops it, such as that created by a seatbelt restraint. The internal organs then continue forward until they are stopped by the force exerted by the rib cage or other body structures. The second law stipulates that force is equal to an object's mass multiplied by its acceleration. This common sense law means that it takes more force to move or stop a heavy object than a lighter object. The third law states that for every action, there is an equal and opposite reaction. Stated another way, for every force, there is a reaction force with the same strength moving in the opposite direction. This principle is important in understanding the kinematics of trauma. If a seatbelt stops a person in a car, the body of that person actually pushes back on the seatbelt, which can result in injuries. Some of the traumatic injury patterns we'll be discussing momentarily include those created by blunt trauma, rapid deceleration, penetrations, and blast injuries. Blunt trauma occurs when a patient's body sustains significant force, but the skin remained intact. The tissues of the body are not penetrated by the external object. These injuries are common with vehicle collisions, which includes motorcycles, bicycles, and pedestrians, sports injuries, and falls from heights. Whenever there is a sudden stop of a body's motion, deceleration injuries can occur, such as the shearing or avulsing of organs or tissues. Deceleration forces can be caused from falls, motor vehicle collisions, shaken baby syndrome, or hangings. Penetrating trauma results when one or more objects break through or penetrate the body's tissues or organs. While gunshot and knife wounds typically come to mind, any object that breaks the skin results in penetrating trauma. Upon assessment, objects may or may not remain impaled in the body's tissues. If they do not remain, that still does not change the nature of the penetrating trauma. Blast injuries are less common but do occur from industrial accidents, acts of terrorism, and military conflicts. There are several different levels of blast injuries that will be explored later in this presentation. Throughout this discussion on traumatic injury patterns, it is important to remember that these patterns need not exist independent of one another. In many instances, a patient will exhibit multiple injury patterns given complex mechanisms of injury. With this in mind, it is imperative for the EMT to assess all possible mechanisms to properly manage and treat potential injuries. Blunt trauma can be caused by a number of different objects. For the time being, however, we will focus on motor vehicle collisions as they produce a unique set of 3 collisions that need to be explored for a better understanding of what happens during such a collision. Understanding the relationship between these 3 collisions will assist the EMT in making the connection between the amount of damage that occurred to the vehicle and the potential injuries that may be evident or hidden within the patient. To begin, it is important to look at the major mechanism, such as car versus light pole. It is just as important, however, for the EMT to be a detective, so to speak, and look at all the little mechanisms that can also add up to significant injuries as well. The first collision occurs when a vehicle collides with another object. The second collision then takes place when the passenger impacts the interior of the vehicle. Lastly, the third collision happens when the internal organs collide against the solid structures of the body. In the context of Newton's laws of motion, since the car was traveling at 50 miles per hour when it hit the light pole, the passenger in the car continues to travel at 50 miles per hour until it meets an external force, such as the windshield, steering wheel, airbag, or seatbelt. The brain and other organs within the body are also traveling at 50 miles per hour until they too are stopped by an external force, such as those exerted by the skull and rib cage when those organs collide with them. Remember the equal and opposite force rule. Each motion or mechanism plays a potentially significant role in the patient's injuries and subsequent outcome. The EMT must look at each level of mechanism in order to assess and treat appropriately. It is not uncommon for vehicle occupants in a collision to sustain multiple system trauma given the various mechanisms and resultant forces involved in the collision. A single incident can result in multiple collisions to the body and its organs. The risk of injury increases dramatically when the occupants fail to wear seatbelts or utilize other available safety restraint systems. The major difference between the types of collisions in such an incident is the direction of the force of impact. The direction of the force varies given a frontal, rear, side, or rotational impact. Vehicle rollovers can produce many of these forces at the same time, resulting in unpredictable injuries. In a frontal collision, the front end of the vehicle is crushed or is distorted as the energy is absorbed and dissipated. While vehicles are designed with crumple zones and other elements to absorb the force of a frontal collision, the speed of the vehicle at the time of the impact, along with the use of internal restraint systems, can play a significant role in the forces transferred to the passengers within the vehicle. In this particular incident, those crush zones do little to reduce the forces experienced by the relatively unprotected motorcyclist. Airbags and seatbelts provide a great deal of safety for vehicle occupants by dissipating energy over time and distance, but they do not eliminate all potential for injury in a motor vehicle collision. When assessing the interior of the vehicle, lift any deployed airbags to inspect the condition of the steering wheel, instrument panel, windshield, and/or dashboard, and also examine the seatbelts for any damage. If occupants were wearing seatbelts improperly or sitting too close to the steering wheel or dashboard, restraint systems can actually contribute to further injury. Given a sudden deceleration, unrestrained passengers in the front seat are at risk for moving up and over or down and under the dashboard. If the trajectory sends a patient up and over the dashboard, the patient's head will typically strike the interior of the vehicle first. The head may hit the windshield, dashboard, mirror, or roof, causing lacerations, contusions, broken bones, concussion, spinal injuries, or worse. If driving, the patient's chest and abdomen may be thrust into the steering wheel, causing contusions, dissections, or ruptures to the vital organs, a fractured sternum or ribs, and other related injuries. The pelvis may also strike the steering wheel while the patient is being pushed upward, causing hip and femur injuries. The down and under trajectory, if it occurs, commonly results in the patient hitting his or her knees on the dashboard, leading to injuries to the knees, femurs, pelvis, and hips. Feet and the bones in the lower leg, tibia and fibula, may suffer twisting injuries given entanglement with the pedals and crushing metal. Spinal injuries are always a potential injury regardless of which mechanism is applied to the body. Attachment points of vital organs to other structures in the body may be subject to tearing injuries. Remember that the motion of the body may stop during a collision, but the organs continue to move inside the body until stopped as well, which can cause a tear at the point of attachment. This type of injury can occur at the aorta, where the heart is attached to the rest of the circulatory system. The kidneys, spleen, and small intestines are also vulnerable. During a rear impact collision, energy is transmitted as a sudden forward accelerating force that ultimately propels the body forward after an initial backward movement relative to the vehicle. Properly positioned headrests help reduce the effect of whiplash, given that the body will typically accelerate with the seat prior to the person's head. If headrests are not properly positioned, the body will accelerate first, causing the neck to first hyperextend back and then flex forward as it catches up to the rest of the body, commonly resulting in a whiplash injury. Beyond injuries to the head and neck, other injuries to the body can also occur, especially if the passenger is unrestrained in the vehicle. Lateral impacts have the potential to cause significant injury to an occupant, especially if the passenger is on the side of the impact. The side of a vehicle has less material and structure than the front or back of the vehicle, meaning that there is less on the side of the vehicle to absorb the forces of an impact than there is in the front or the back. Side curtain airbags are becoming prevalent in many vehicles now, but those systems do not benefit from the cumulative benefits of front or rear crumple zones. Given a side impact, significant forces are commonly transferred directly into the pelvis and torso, especially if the collision is powerful enough to result in compartment intrusion, the movement of the vehicle's structural components into the patient compartment. Because the body is less tolerant of lateral bending, the probability of internal tearing or shearing injuries increases with the lateral impact collision. Aortic tears or dissections, as well as rib, chest, and extremity injuries are more common with a side impact. If the vehicle is struck above the center of gravity, it is possible the vehicle will rock away from the side of the impact and cause lateral whiplash injuries to the neck. Direct blunt force trauma to the head is also possible by striking the side of the patient compartment. Rotational impacts combine both lateral and frontal or rear collision forces, which can produce a combination of injuries associated with each. These types of impacts occur when vehicles collide at an angle or when a side impact occurs toward the front or rear of the receiving vehicle, resulting in a horizontal axis rotation of the vehicle. Due to the multiple strikes involved with this mechanism, injuries from rollover accidents are unpredictable and have the greatest potential to cause lethal trauma to all passengers inside the vehicle. If unrestrained prior to a rollover accident, injuries tend to be even more severe. The chance of ejection from a vehicle increases dramatically if a passenger is not using seatbelts. If ejected, the passenger will commonly encounter secondary injuries from striking objects that are much less forgiving than the interior of a vehicle, such as concrete, asphalt, gravel, stones, roadway obstructions, trees, other vehicles, and the like. Given these secondary impacts, ejection from a vehicle increases the likelihood of fatal injuries by 25 times when compared to someone secured within the vehicle with a seatbelt. If a patient is ejected from a vehicle, the further away from the vehicle the person is, the greater the forces involved in the collision, which provides the EMT with an idea of the amount of energy the patient may have absorbed. Moving away from the topic of motor vehicle collisions, we will now look at injuries resulting from rapid or sudden deceleration of the body. While these injuries may result from a motor vehicle accident, there are other situations that may result in deceleration trauma. Some examples include falls from a height, shaken baby syndrome, sports injuries, especially in contact sports, or any other circumstance that results in an abrupt stop to a person's moving body. Given the forces involved in a sudden stop of a moving body, injury mechanisms such as shearing, avulsing, contusing, crushing, or rupturing are common. Due to the head's physical size and weight in proportion to the rest of the body, the head and brain are very susceptible to deceleration injuries. Deceleration injuries are also common in the chest, the abdominal cavity, and in the retroperitoneal cavity. Shearing injuries to the aorta, ruptured organs, and organs tearing at points of attachment can all result from deceleration trauma. Penetrating trauma occurs when an object breaks through tissue, commonly the skin, to enter the body. This can occur from an object on its own or in combination with blunt trauma or a blast injury. Tissue damage is influenced by the distance an object travels within the body, the size and nature of the object, and the forces exerted by the object onto or within the body. In the case of a bullet, the mass, size, and velocity of the bullet are all factors, as is any fragmentation of the bullet within the body and resulting cavitation that occurs as the bullet passes through the tissues. Fragmentation can refer to the breaking up of the bullet itself, as well as the tissues or bones impacted by the bullet. The degree of bullet fragmentation is commonly affected by bullet construction, as some bullets are engineered to break apart once in contact with a solid object, such as a person's body, to cause greater damage. Cavitation is a temporary void space within the tissues caused by a bullet. Cavitation occurs behind the bullet on its path of travel and can create additional damage to tissues as the cavitation collapses. Bullet injuries are usually the most severe in solid organs, such as the liver or brain, because of fragmentation and cavitation. The density of the body structure or structures impacted can play a part in the overall severity of the injuries, as some tissues are more accommodating of penetrating trauma than others. While weapons are often considered when discussing penetrating trauma, virtually any item can result in penetrating trauma if significant force is applied. Pencils, scissors, forks, and nails are all examples of common objects that are often involved in penetrating trauma. When evaluating penetrating trauma, the amount of energy involved plays a significant role in the injuries sustained. Stabbings are considered low-energy events. True, significant damage may still occur depending on the area of the body affected, but the trauma tends to be localized to the area of the penetration. On the other side of the spectrum are injuries created by high-energy events, such as the trauma inflicted by military weapons. The damage created by these penetrations tends to be significant, with death being highly probable, even if a vital organ or body structure was not directly impacted. In between those two extremes are medium-energy events, such as penetrating trauma created by bullets fired from handguns. Significant damage and death is still possible, but injuries to non-vital areas do not prove to be as fatal as those suffered from high-energy events. Blast injuries result from being too close to an explosion. While more commonly thought of in military settings, blast injuries can also occur in industry and residential settings as well. Industrial accidents involving compressed gases or chemicals, especially in the presence of fire, are common causes of explosions. Within a home, igniting natural gas leaks, or flammable liquid vapors may generate an explosion as well. Explosions create a rapid compression of the air, resulting in blast waves, blast winds, and ground shock. Explosions can also result in a release of significant heat as well as shrapnel, especially if the explosion was related to a bomb or an improvised explosive device. Blast injuries resulting from explosions can be rather nasty as multiple mechanisms are commonly involved. Blast waves can cause disruption of major blood vessels in the body, rupture of major organs, and lethal cardiac disturbances. Blast winds and ground shock can contain enough force to collapse buildings. These same forces exerted on a human body can produce very lethal results. There are 4 different types of blast injuries: primary, secondary, tertiary, and miscellaneous. Primary blast injuries result from the pressure wave produced by an explosion. This is a blunt force trauma to the body. Secondary blast injuries are caused by flying debris propelled by the explosion. Blunt force and penetrating trauma injuries are common. Tertiary injuries occur as a patient is thrown into a stationary object, resulting in deceleration injuries, along with potential for more blunt force trauma and penetrating injuries. Injuries such as burns, crushing injuries from a collapse, or inhalation of toxic chemicals are all considered miscellaneous blast injuries. In any type of blast injury or explosion, the EMT should expect to see multi-system trauma affecting all organs and body systems. The type of blast and the proximity of the patient to the explosion should assist in determining the extent of the injuries. Common signs and symptoms associated with a blast injury may include any of the following: respiratory distress given burns to the respiratory tract, swelling to the airway, pneumothorax, or other complications associated with blunt trauma. Damage to blood vessels in the heart, which can compromise blood flow and the patient's ability to maintain an adequate blood pressure. Central nervous system compromise, especially when the brain or spinal cord is damaged as a result of the blast. Hearing loss given damage to the ear's tympanic membrane, eardrum, as a result of the pressure change associated with the blast wave. Damage to vital organs given blunt, penetrating, or deceleration trauma. Orthopedic injuries, including broken bones and dislocated joints. And soft tissue issues commonly associated with tertiary or miscellaneous blast injuries. When initiating the management of blast injuries, EMS providers must approach each patient assuming to find evidence of multi-system trauma. Rapid treatment and transport is warranted for most of these patients. In circumstances where there are multiple victims from the same blast incident, multiple casualty care triage should be implemented. When mitigating incidents with multiple trauma victims, it is important to have a procedure by which trauma patients are identified and categorized to provide care as effectively as possible given constrained or limited resources. The Centers for Disease Control and Prevention, CDC, has recommended guidelines available for trauma field triage. Resources pertaining to the CDC guidelines for the field triage of injured patients are available on their website at cdc.gov/fieldtriage. In the fall of 2012, the Wisconsin EMS Advisory Board and Statewide Trauma Advisory Council, STAC, adopted the Model Uniform Core Criteria, MUC, for mass casualty incident triage standards available at ems.gov. At the time this presentation was produced, SALT Triage was the only triage system that met all criteria, although many services still utilize START and JumpStart triage as well. There is no specific state mandate to use a specific system, so long as each service has protocols governing the triage of patients in a mass casualty incident. More information on triage and mass casualty responses is included in the EMS operations module of this course. The golden hour, now commonly referred to as the golden period, is the duration of time from the occurrence of a serious injury to the receipt of definitive care. Many trauma patients, especially those with multi-system trauma, will need care beyond what can be given in the pre-hospital setting. To increase the patient's chance of survival and full recovery, definitive care, which may include surgical intervention, should be received within the first 60 minutes after a serious injury occurs. In recognizing that EMS is a very important component within this golden period, the Platinum 10 minutes has been identified as a nationwide standard to emphasize the need for EMS to minimize its on-scene time. Unless there are extenuating circumstances beyond the EMS crew's control, such as a lengthy extrication, On-scene time should not exceed 10 minutes. While the components of the patient assessment survey remain the same for every patient, the amount of detail in the assessment and the order in which the assessment is performed may change based on the mechanism of injury. All responses require a scene size up to be performed to choose the correct personal protective equipment and body substance isolation for the situation. Hazards may be apparent or hidden to responding crews, so a complete scene survey for safety concerns starts at the beginning of the incident and continues until the incident is complete. Next, the mechanism of injury will dictate what type of assessment is needed and in what order it should be performed. Based on dispatch information, the EMS crew may be able to determine the need for additional resources even before the crew arrives on the scene. Once patient contact is initiated, the primary assessment should reveal any immediate life threats to be treated, such as mental status variations, airway compromise, breathing difficulty, or circulation issues. The mechanism of injury and patient presentation, in conjunction with the primary assessment, will then dictate if the secondary assessment is performed on scene or while en route to the hospital. The secondary assessment includes all history taking and an appropriate systematic physical exam based on the mechanism of injury involved. The physical exam may be focused on a specific body system, or it may be a head-to-toe trauma assessment. Trending the patient's condition and status is accomplished during the reassessment stage. Given a critical patient, reassessment should be performed every 5 minutes. If the patient is stable, reassessing every 15 minutes is the standard. Mechanism of injury can be divided into two categories: significant and non-significant mechanisms. Significant mechanisms of injury include, but are not limited to, any multi-system trauma patient, vehicle crashes with compartment intrusion, falls from significant heights, pedestrians versus vehicles, motorcycle crashes, and death of an occupant within the same vehicle, given a motor vehicle collision. Non-significant mechanisms include, but are not limited to, isolated trauma to a body part and falls without a loss of consciousness. Anytime a pediatric or geriatric patient is involved in trauma, there are some special considerations to evaluate. These considerations will be discussed in greater depth later within this presentation. As more of the story becomes available during the assessment process, it is important for the EMS crew to continually reevaluate the mechanisms of injury in light of their assessment findings to properly manage and treat potential injuries. Other special considerations an EMS crew should think about include C-spine precautions, ALS interventions, air medical support, and the destination facility for the patient. It is warranted to take spinal precautions for patients with significant mechanisms or if the mechanism is unknown. It is always easier for the ED to remove C-spine equipment once the patient is cleared than to try and fix damage done by aggravating a non-immobilized C-spine injury during transport. Advanced life support may not be available in all cases, but the EMS crew should consider calling for ALS support with a trauma patient. Fluid replacement, pain control, and other ALS interventions may significantly improve the patient's outcome depending on the mechanism and resultant injuries. Each service should have protocols regarding the criteria for calling aeromedical support and for determining the destination hospital for the patient. The extent of the patient's injuries, in addition to the transportation time, play a significant role in deciding whether or not these additional resources are warranted and what hospital would be the best to appropriately treat the patient. We'll be discussing some of these criteria in greater depth within this presentation. If you recall from your patient assessment module, the acronym AVPU is utilized to assess a patient's mentation. A is alert, V is responsive to verbal stimuli, P is responsive to painful stimuli, and U is unresponsive. This is a rather rudimentary measure of mental status, however, and other scoring scales exist to better quantify a patient's mentation. For the next few minutes, we'll be discussing two such scales, the Glasgow Coma Score, GCS, and the Revised Trauma Score, RTS. Anyone who has sustained a head injury can exhibit subtle changes in mentation rather quickly, depending on the underlying pathology of their injury. It is important for EMS providers to measure a baseline mental status on their patients and then reassess this measurement throughout their assessment and care of the patient. The Glasgow Coma Score is a convenient method to quantify and trend a patient's mental status, and many providers use this score to assess neurological function in any altered mental status patient, even if it is not trauma-related. The first criteria evaluates the ability of the patient to open his or her eyes. If the patient can open his or her eyes spontaneously without the EMT taking any action, the patient receives a score of 4. If the EMT needs to talk to or shout at the patient for such a response, the patient receives a score of 3 in this category. If painful stimuli is required for the patient to open his or her eyes, a score of 2 is awarded in this category. If the patient's eyes remain closed after all of the attempts, award the score of 1. When evaluating this category, be mindful of the injuries sustained by the patient. If the patient sustained a direct injury to his or her eyes, it may not be possible or prudent to evaluate this category. The next category quantifies the ability of the patient to communicate effectively. If the patient is oriented and can answer questions appropriately, a score of 5 is awarded. If the patient is confused or disoriented but can still communicate, award a score of 4. If the patient answers with inappropriate words that indicate more than just simple confusion, a score of 3 is appropriate. For instance, if the EMT asks the patient what time it is and the patient responds, "red shoes," that would be considered inappropriate words, as the response exhibits more than just simple confusion on the part of the patient, who may otherwise respond with a time, even though that time may be incorrect. If the patient's response is incomprehensible, a 2 is scored in this category. Lastly, if the patient cannot provide a verbal response, a score of 1 is assigned for this category. The last category categorizes a patient's gross motor function. A patient who follows commands appropriately should receive the highest score in this category, a 6. For instance, a common request is for the patient to show 2 fingers, or something along those lines. It is a simple, quick request that can be used to assess the patient's motor skills. If the patient fails to follow simple commands, the next step would be for the EMT to provide some type of painful stimulus to the patient, such as a pinch to the nail beds or trapezius muscle or a sternal rub. If the patient attempts to remove the painful or irritating stimulus, a score of 5 should be awarded. Withdrawing or pulling away from a painful stimulus should be awarded a score of 4. If the patient is unresponsive up to this point, the EMT should determine whether or not the patient exhibits any neurological posturing tendencies. Posturing commonly indicates a very serious brain or brainstem injury and can be a rather grave sign for trauma patients. Decorticate posturing is when the patient flexes their arms and wrists toward the core of the body while extending their legs and feet. If decorticate posturing is visible with or without a painful stimulus, the patient is scored a 3 in this category. Extension to pain, called decerebrate posturing, involves extension of the arms with the shoulders rotated inward toward the midline, along with wrist flexion and leg extension. If decerebrate posturing is noted, the patient should receive a score of 2 in this category. Remember that decorticate and decerebrate posturing can occur with or without painful stimulus, so be aware of this when performing a GCS assessment. If there is no motor response noted at all after all these steps, this category is scored as a 1. Once these 3 evaluations are completed, the scores are then added to generate an overall Glasgow Coma score. As you may have noticed, the lowest score possible is a 3. Even a corpse earns a score of 3 in this scoring system. On the other side of the scale is a maximum score of 15, reflecting no neurological deficit. When assessing infants and small children, the assessment process is modified slightly to accommodate the lack of communication skills development within that age group. When assessing the verbal response category, coos and babbles are indicative of an oriented infant. Irritable cries are reflective of confusion, and crying only in the presence of painful stimulus is scored at a 3 for inappropriate words. The Revised Trauma Score, RTS, delves even deeper by combining a neurological assessment, the GCS, with physiologic assessment criteria such as the patient's systolic blood pressure and respiratory rate. Each category is scored on a scale of 0 to 4 with a resultant combined RTS of 0 to 12. Please refer to the table provided for the scoring associated with the various criteria. Both the GCS and the RTS assist the EMS provider in quantifying a patient's baseline presentation which then provides the basis for trending of the patient's status during subsequent reassessments. In some systems, these scores are also utilized to determine the level of the trauma facility to which a patient should be transported. We'll be discussing trauma care levels in just a little bit. Please keep in mind that both scales are intended to be used as a quick reference. Scene time should not be delayed so that the EMS crew can collect and record scores. These assessments can be, and should be in the case of reassessments, performed during transport. Wisconsin has a formal trauma care system in place designed to reduce death and disability resulting from traumatic injury by decreasing the incidence of trauma, providing optimal care of trauma patients and their families, and collecting and analyzing trauma-related data. As a part of this goal, hospitals are asked to participate in a rating process developed by the American College of Surgeons to identify the trauma care readiness of the facility. Within this system, hospitals are designated by the levels 1 through 4. Each level is capable of specific treatments and interventions based on availability of staff, equipment, and resources. A Level 1 trauma center provides the highest level of around-the-clock trauma care by providing availability of trauma surgeons, operating rooms, and diagnosing equipment such as MRIs and CAT scans and specialty treatment 24 hours a day, 7 days a week. Level 1 hospitals are characterized by their capacity to provide leadership and total care for every aspect of traumatic injury from prevention through rehabilitation, including research. Given these stringent requirements, only a few hospitals within Wisconsin are denoted as Level 1 trauma centers. Level 2 hospitals provide initial definitive trauma care regardless of the severity of the injury, but differs from Level 1 facilities in teaching and research capability. Level 3 hospitals provide assessment, resuscitation, stabilization, and emergency surgery, but must arrange transfer to a Level 1 or 2 facility for definitive surgical and intensive care as necessary. Level 4 facilities provide stabilization and advanced trauma life support prior to transferring the patient to a Level 1 or 2 facility. Unclassified facilities have either chosen not to be a part of the trauma care system or have not been approved as a Level 1, 2, 3, or 4 facility. At the time this video was produced, 124 of 126 potential hospitals participated in the Wisconsin trauma care system, with 9% of them being ACS certified Level 1 or 2, and the remaining qualifying as Level 3 or 4. More information on Wisconsin's trauma care system can be found at www.dhs.wisconsin.gov/trauma/classification. In 2012, the State of Wisconsin Department of Health Services updated its trauma field triage guidelines based upon the CDC 2011 guidelines for field triage of injured patients. These guidelines are designed to assist EMS providers in determining where the trauma patient should be transported. For instance, there are times when an EMS crew may have to decide whether a longer transport time is warranted to reach a higher level trauma center or if the closest facility should be chosen. The first criteria in this decision matrix is to assess the patient's airway. If the EMS crew cannot secure an airway, driving further to reach a higher level trauma center is counterproductive if the patient cannot be ventilated during that longer transport. As a result, if the patient is not ventilating on his or her own, or the patient cannot be ventilated by the EMS crew, it is imperative for the crew to transport the patient to the nearest appropriate hospital for definitive airway management. Additionally, if ventilation is an issue, the crew should consider utilizing ALS or air medical resources if available. On the other hand, if the crew can adequately ventilate the patient, or the patient is adequately ventilating on his or her own, the next step in the matrix should be performed. Following the airway assessment, the EMS crew needs to obtain vital signs and assess the patient's level of consciousness. If the patient has a GCS of 13 or less, a systolic blood pressure of 90 millimeters of mercury or less, or a respiratory rate that is less than 10, greater than 29, or they need ventilatory support, the patient should be transported to the highest level trauma care facility available within the region. Please note that if the patient is an infant less than 1 year old, the respiratory rate criteria is modified. Because young infants have fast respiratory rate compared to adults, A rate below 20 breaths per minute is indicative of significant underlying problems necessitating higher level care. Additionally, if there is an abnormality noted in the pediatric patient's appearance, work of breathing, or circulation to the skin, this criteria is met and the patient should be transported to the highest level care facility available. If available within the region, a pediatric trauma center is preferred for any pediatric trauma patient meeting any of these criteria. If the patient does not meet any of these criteria, the next step is to assess the anatomy of the injury. Assuming the patient's vital signs and level of consciousness are acceptable, the injury itself should be evaluated. Given the nature of certain injuries, transportation of the patient to the highest available trauma facility is prudent. As before, if the patient is pediatric, a pediatric trauma center is preferable. The list of these injuries include penetrating injuries to head, neck, torso, and extremities proximal to the elbow or knee, chest wall instability or deformity, 2 or more fractures involving the femur or humerus, crushed, degloved, mangled, or pulseless extremity, complete or partial amputation proximal to the wrist or elbow, pelvic fracture, unstable pelvis, open or depressed skull fractures, or new onset paralysis, paraplegia, or quadriplegia. If the patient does not present with any of these injuries, then the EMT should evaluate the mechanism of injury with an emphasis on recognizing evidence of a high energy impact. In assessing the mechanism of injury, the following are considered to provide evidence of a high energy impact. Falls of greater than 20 feet for adults, or for children, greater than 10 feet, or 2 to 3 times the height of the child. High-risk auto collision, which includes compartment intrusion including the roof greater than 12 inches at the occupant site or 18 inches at any other site, ejection, partial or complete, of the patient from the vehicle, death of an occupant in the same passenger compartment as the patient, or, while it may not be possible for the EMS crew to obtain on the scene, vehicle telemetry data consistent with high risk of injury. Auto versus pedestrian or bicyclist collisions, with the pedestrian or bicyclist being thrown, run over, or struck by a vehicle with a significant impact, which can be assumed if the vehicle is traveling at greater than 20 miles per hour. Or motorcycle crash involving speeds greater than 20 miles per hour. If any of these criteria are met, the patient should be transported to a trauma care facility, although that facility need not offer the highest level of trauma care. If these criteria are not met, the last step is to evaluate special patient or system considerations. To assess for special patient or system considerations, begin by evaluating the age of the patient. The risk of injury or death from a traumatic incident increases once a person reaches 55 years of age. For those over 65 years of age, a systolic blood pressure of less than 110 millimeters of mercury may actually be indicative of shock. Lastly, low-impact mechanisms, such as a ground-level fall, may result in severe injury to an older patient. These types of patients should be transported to a trauma care facility. As far as children are concerned, the EMS crew should always consider transporting pediatric patients to a pediatric-capable trauma center. If the trauma patient is taking anticoagulants or has a bleeding disorder, any type of head injury can be a cause for concern. If burns are involved, transport to a burn facility if there is no trauma mechanism. Otherwise, transport to a trauma center if other trauma is involved. Pregnant patients, especially those more than 20 weeks pregnant, are at greater risk for complications given a traumatic injury and should be transported to a trauma care facility. If none of these criteria apply, the patient should be transported according to local protocol, although there are instances in which an experienced EMS provider may elect to transport to a trauma care facility based upon his or her professional judgment. According to CDC statistics, accidents, unintentional injuries, are the #1 cause of death in the United States for people 1 through 44 years old. Throughout the ages of 1 to 14 years, approximately 1/3 of all deaths are caused by accidents, trauma. This number increases significantly to over 40% in the 15 to 19 age range. Blunt trauma tends to be the most common injury for pediatric patients. It should be clear from our study of anatomy, physiology, and lifespan development that pediatric patients are not simply small adults. There are significant anatomical differences between pediatric and adult patients that result in different injury patterns across those groups, even with the same mechanism of injury. A car striking a pedestrian, even if at a very low speed, is a very different scenario if the pedestrian is a 3-foot tall 5-year-old as opposed to a fully grown adult. Additionally, as an infant grows, so too does the exposure and risk factors for potential injury. Infants become toddlers who learn to walk and explore their environment with greater rigor. School-aged children are even more active, usually participating in sports and other activities such as riding bicycles that can lead to traumatic injuries. Once the teenager is old enough to drive, a lack of experience coupled with delusions of invulnerability and heightened risk-taking leads to more significant injuries given higher energy collisions. Unfortunately, physical and emotional abuse and neglect are also regular occurrences within our society, and children are less able to protect themselves and seek outside assistance. According to the National Pediatric Trauma Registry, motor vehicle collisions, which also include crashes involving bicycles and pedestrians hit by automobiles, are the most threatening to the pediatric population. Speeds greater than 25 miles per hour are considered medium to high-speed collisions when a pediatric patient is involved. Unrestrained vehicle passengers are propelled against the interior surfaces of the vehicle during a collision, and unrestrained pediatric patients are even more prone to head and neck injuries given differences in anatomy when compared to an adult patient. While car seats, seat belts, and other vehicle restraint and safety systems reduce the number of serious injuries found in these patients, improperly positioned straps and belts can actually increase the incidence of trauma to the abdominal area and lumbar spine areas. Placing rear-facing car seats in front of airbags or otherwise installing car seats incorrectly can also result in serious injury given a collision. Children struck by vehicles while riding bicycles typically sustain head, spinal, and abdominal injuries because they tend to be propelled up and over the handlebars before striking the pavement. Pediatric pedestrians struck by vehicles commonly present with abdominal injuries, including internal bleeding, thigh and pelvis injuries, and injuries to the head and spine. The location of these injuries are dependent on the type and size of the vehicle in conjunction with the height of the child. If an adult sees that he or she is about to be struck by a vehicle, the person will commonly try to move away from the vehicle. Children, on the other hand, tend to turn in and face the vehicle before being struck, which results in different and commonly much more severe injuries in children struck by vehicles than adults given the same collision. In the adult patient, falls from a height 3 times that of the patient's height are considered to be significant. Significant falls for the pediatric patient, on the other hand, are those from a height of greater than 10 feet without a loss of consciousness or less than 10 feet with a loss of consciousness. Main areas in which injuries commonly occur include the head and spine. Remember that the younger child's head is larger in proportion to the rest of his or her body. Given a fall, it is very common for the head to strike the ground first. Extremity injuries are also common during moderate and significant falls. The seriousness of the injuries will obviously vary given the age of the child, the surface onto which he or she fell, and the height of the fall. Very young children tend to have softer, more flexible bones, so orthopedic injuries may not be as prevalent in pediatric trauma. While burn injuries are covered in much greater depth in the module on soft tissue injuries, there is cause for note here given that burns to pediatric patients are generally more serious than adults because pediatric patients have more surface area relative to their total body mass. This can cause more fluid and heat loss. Damaged skin can also become infected more easily and create additional complications during the healing process. Accidental burn injuries can occur at any age, but children are more susceptible given their cognitive development level. Child abuse victims can also receive burns intentionally by caregivers, parents, or others. Localized cigarette burns on the skin or circumferential dunking burns around the legs or buttocks that occur by dunking an infant into scalding bath water as a punishment should raise suspicion of suspected child abuse. When evaluating a pediatric patient with a burn injury, it is important for the EMT to look at the pattern created by the burn in conjunction with the story of how the burn occurred. As discussed elsewhere in this course, if child abuse is suspected, the EMT has a legal obligation to report it to the proper authorities. Sports-related injuries can be commonplace within the pediatric population, and the nature of those injuries can be as varied as the individual sports in which the child is participating. Safety equipment such as helmets and protective padding can help reduce the seriousness of injuries. Despite these precautions, however, trauma to the head, neck, spine, and extremities are still relatively commonplace in sports-related injuries. With significant backing from the NFL, there has been significant focus recently on sports-related concussions, and Wisconsin now has a law, State Statute 118.293, regarding concussion prevention for children participating in organized sporting activities. More information regarding concussions is available in the head, neck, and spine module of this course. According to the Children's Bureau of the U.S. Department of Health and Human Services, there were more than 3.6 million individual reports of child abuse or neglect within the United States in 2010. These reports encompassed a total of almost 1.45 million individual children. Approximately 754,000 children were victims on more than one occasion. Of those children, 1,537 died as a result of their abuse or neglect. Reporting of abuse and neglect is made to the National Child Abuse and Neglect Data System. Under the Federal Child Abuse Prevention and Treatment Act, 24 U.S.C. Section 5101, child abuse and neglect is defined as any recent act or failure to act on the part of a parent or caregiver which results in death, serious physical or emotional harm, sexual abuse or exploitation, or in act or failure to act which presents an imminent risk of serious harm. While each state codifies abuse and neglect differently, they commonly recognize neglect, physical abuse, psychological maltreatment, and sexual abuse as categories of child abuse and neglect. Given the data provided by the National Child Abuse and Neglect Data System, a finding of neglect is the most common, impacting 78.3% of the 1.45 million victims in 2010. Those suffering from physical and sexual abuse account for an additional 17.6% and 9.2% respectively. This is an issue that cuts across racial and ethnic boundaries. 88% of all victims were categorized as African American, Hispanic, or white. 44.8% of the victims were white, 21.4% were Hispanic, and 21.9% were African American. Parents are the most likely perpetrators of abuse. 81.2% of duplicate perpetrators of child maltreatment were parents. Believe it or not, women are more likely to abuse children than men. 53.6% of all perpetrators were women. While it is not necessary to memorize any of these statistics, it is important for an EMT to understand them. Common stereotypes regarding the perpetrators of abuse are not valid, and it is important for the EMT to dispel any personal bias and evaluate circumstances objectively and critically when child maltreatment is suspected. Statistically speaking, the most common perpetrator of child maltreatment is the Caucasian mother of the child. Just because the EMT responded to an affluent suburban neighborhood does not mean child abuse and neglect is not a possibility. Witnessing the aftermath of child abuse and neglect can tug at the heart of the EMT and lead to increased stress both during and after the call. It is important to remain objective and professional at all times when providing care. If necessary, consider assistance from law enforcement if the circumstances surrounding the injuries are suspicious or if the environment seems volatile. Admittedly, these types of calls can be very difficult to handle. Children are minors who lack the capacity to accept or decline medical treatment. If abuse is suspected, however, there is no guarantee that the child's guardian will make a healthcare decision based on the best interests of the child. Additionally, there can be a fine line between acceptable discipline of a child and physical abuse. To address these concerns, Wisconsin law, State Statute 48.981, mandates emergency medical technicians to report suspected child abuse or neglect to law enforcement or other appropriate agency. If the child is deemed to be in immediate danger, law enforcement has the authority to take necessary action to protect the child, even if the guardian does not consent to the action. Additionally, the statute provides both civil and criminal immunity for the EMT who reports in good faith under the statute. Good faith reporting is presumed, meaning that the burden to establish bad faith falls on the alleging party, not the defendant EMT. If an EMT fails to report suspected abuse or neglect, penalties can include a $1,000 fine and imprisonment up to 6 months. Additionally, there is no immunity protection afforded to a person who fails to report. If a failure to report results in further harm to a child, it is foreseeable that civil litigation and possibly criminal charges may result. Unfortunately for the EMT, child abuse victims do not wear signs or identification bracelets that identify them as abused or neglected individuals. EMS providers need to be observant and thorough in their care and assessment of the pediatric patient suspected of being a victim of maltreatment. The provider should look for multiple bruises in various stages of healing, commonly in areas not typically or easily bruised. It is not unusual for a toddler to have scrapes or bruises on the hands, knees, or elbows. Bruises on the back, buttocks, or face, however, are harder to explain. The shape of a bruise can be telling as well. Bruises in the shape of a hand or fingers, including circumferential bruising around the arms, should raise a red flag for the EMT. Any injuries that are inconsistent with the mechanism described by the caregiver should be noted and documented. An infant falling off the sofa should not have a depressed skull fracture, broken ribs, or various bruises on the body. Multiple responses to the same address over a period of time for pediatric traumas may require some investigation. As noted previously, accidental burns in children can be common. Burns that leave grate or grill imprints, numerous cigarette burns, or circumferential burns to the extremities or buttocks, however, are typically intentional. If parents or caregivers seem inappropriately concerned or, on the other hand, have minimal interest in what is happening to the child, the EMS provider should also take note. If the EMT suspects abuse, it is beneficial to speak with the caregivers separate from the pediatric patient if possible. Conflicting stories are red flags. If the child is withdrawn or is fearful of telling how the injury occurred, it may be because he or she is afraid of subsequent reprisal by the caregiver once the EMS crew leaves. Neglect is another form of maltreatment that can present differently from physical abuse. When responding to a scene, it is important for the EMT to assess the environment as well as the child. Look for lack of supervision or an unsafe living environment. In neglectful homes, older siblings are sometimes in charge of the younger children. Note the cleanliness of the living environment, and, if possible, try to gauge if adequate nutrition is available. If your pediatric patient has been diagnosed with a chronic illness and necessary medications are not available, it may be a sign of neglect. As with all EMS patient interactions, detailed, objective documentation is vital in these cases. Sad as it may be, sexual abuse can occur to anyone regardless of their age or gender. This may also include infants, toddlers, and other young children. Some of the signs an EMT may discover during assessment of a pediatric sexual abuse victim include difficulty walking or sitting, stained or bloody underclothing, an inappropriate interest or knowledge of sexual acts, nightmares, or bedwetting. Overcompliance with physical exams, regressive, or aggressive behavior are also potential red flags. Fear of or a lack of connection or eye contact with a specific person or caregiver should also raise the EMT's suspicions. Shaken baby syndrome is a specific form of child abuse, referred to as abusive head trauma or inflicted traumatic brain injury. While it was first recognized in the 1970s, many myths still persist regarding shaken baby syndrome, and research continues to shed light on this type of abuse. For instance, it was once believed that most perpetrators of abusive head trauma were men. Research as recent as 2011, however, shows that women are just as likely as men to be responsible for pediatric injuries associated with shaken baby syndrome. With this being said, men are more likely to confess to the crime and are also prosecuted in higher numbers. Additionally, age plays a factor between the two genders. The median age of male perpetrators is 27 as opposed to 34 for women. With those differences in mind, the actions of male perpetrators typically result in more significant injuries, and death is more likely at the hands of a man than a woman. According to the CDC, shaken baby syndrome is the leading cause of child abuse deaths in the United States, despite the fact it is 100% preventable. An estimated 1,200 to 1,400 children are injured or killed each year in the United States due to shaking. For whatever reason, approximately 2/3 of all victims are boys. While this type of abuse has been known to occur in children up to the age of 5, infants less than 1 year old are at greatest risk. As you are already aware from your previous studies within this course, infants and small children have larger heads in relation to the size of their bodies, and their neck muscles are not fully developed. When an adult forcefully shakes a young child back and forth, it actually creates a whiplash motion similar to that which occurs in a car accident. Unlike a car accident where the head moves forward and back once or twice, this whiplash motion actually occurs repeatedly, commonly 2 to 4 times per second over a period of 4 to 20 seconds. After the shaking episode, it is not uncommon for the child to be thrown back into a crib, onto a bed, or some other surface. If the baby does stop crying, it usually is due to the brain trauma sustained by the child. Ultimately, the brain rotates within the skull cavity, injuring or destroying brain tissue. Blood vessels supplying the brain can also be torn, which leads to pooling of blood within the skull, which can cause additional brain damage. Retinal bleeding is also a common sign of this type of injury. Child victims of shaken baby syndrome may present with extreme irritability, seizures, limp extremities, rigidity, posturing, decreased level of consciousness, inability to focus, unequal pupils, vomiting, or the inability to suck or swallow. In more severe cases, respiratory or cardiac function may be compromised, which may result in death. These signs may occur in children for reasons other than non-accidental trauma, shaken baby syndrome, so it is important for the EMT to ensure an adequate caregiver interview to piece together what may have happened. If the caregiver states the child has been sick and vomiting, it would be important to know if the child also had a fever. Was the child eating regularly? If not, when did the child last eat and when did the vomiting start? Are others in the house not feeling well? How about the child's bowel movements? Have the diapers been wet or dry? Any diarrhea? What about recent trauma? If stories are not consistent between caregivers, the story seems to change, or the information provided sounds somewhat implausible, it may be cause for the EMT to be suspicious. A simple fall off the couch or bump to the head will not produce the same type of injuries seen with abusive head trauma. If suspicions are raised, be sure to communicate that information with hospital staff upon transport. If necessary, do not hesitate to involve law enforcement. Shaken baby syndrome is important to diagnose because of the long-term consequences associated with that type of abuse. Child victims of inflicted traumatic brain injury can ultimately suffer from learning disabilities, physical disabilities, visual disabilities including blindness, hearing impairment, speech disabilities, cerebral palsy, seizures, behavioral disorders, cognitive impairment, or even death. As these injuries are preventable, significant effort has been made to educate the public about shaken baby syndrome and how to cope with crying babies. Additional resources are available from the National Center on Shaken Baby Syndrome at www.don'tshake.org and the Centers for Disease Control and Prevention at www.cdc.gov. While trauma is a problem throughout the entire population, it is important to understand the body systems of the pediatric patient and the role played in resulting injury patterns after a traumatic mechanism. Remember that a child's head is relatively larger in proportion to their body size, and, because of its relative weight, the head tends to make contact with environmental surfaces before other parts of the body. Because the head is larger, immobilizing a pediatric patient on a longboard can prove challenging because the occipital area of the head is not flush with the back. When placed on a longboard, this anatomical feature will cause the head to flex forward, potentially causing airway compromise. Placing a small towel behind the shoulder blades prior to spinal mobilization can help maintain the airway in a neutral position for the pediatric patient. Airway structures are smaller in a pediatric patient, and the mouth and nose are even smaller in proportion to the entire pediatric respiratory system. The trachea is softer and more flexible than in adults, and the pediatric tongue is proportionally larger inside the mouth. All of these airway differences can result in respiratory compromise after a traumatic incident. In situations involving a respiratory compromise, maintaining the pediatric airway with a jaw thrust maneuver becomes a priority after the traumatic event. The bones of a pediatric patient are softer and more pliable than those of an adult, so chest trauma usually does not produce broken ribs. With that being said, there may be significant injuries to internal organs without any external signs. The ribs in the pediatric patient move more horizontally than vertically during inspiration because of underdeveloped intercostal muscles, so children rely heavily on the diaphragm for breathing. Given this increased reliance on the diaphragm by the pediatric patient, any trauma to the chest or abdomen can significantly compromise their breathing effort. Simply placing a securing strap across a child's abdomen during patient immobilization can contribute to breathing complications. Young children normally have protruding abdomens. As a result, there is not a lot of inherent protection from trauma in the abdominal area. Pediatric abdominal trauma can prove very serious as hidden injuries to internal organs can be prevalent. As previously stated, infants and young children are diaphragmatic breathers. Any injuries to the abdomen may negatively impact a child's ability to breathe adequately. If CPR or ventilatory assistance is being provided by an EMT, gastric distension can be a significant problem as air in the gastrointestinal system can distend the abdomen, creating pressure on the diaphragm, which can further impede positive pressure ventilations. A child's body surface area is also larger in proportion to their body mass, so infants and young children are more prone to heat loss. Keeping pediatric patients warm after a trauma event can help in slowing the progression of shock. Given the amount of blood supplied to the head, people lose a great deal of body heat through the head. In children, this is even more pronounced given the larger relative size of the head to the body. Wearing a hat or covering a pediatric patient's head with a towel or blanket will help them retain body heat. Lastly, children have significantly less circulating blood volume than an adult. A newborn has less than 355 millimeters and an 8-year-old has about 2 liters. Adults, by comparison, commonly have about 5 liters of blood. Because they have less blood to spare, moderate blood loss is commonly life-threatening in pediatric patients. On the opposite end of the age spectrum are geriatric patients who also present with their own special set of challenges after a traumatic event. Not only do body system changes have dramatic effects on routine daily activities, those changes are also profound concerning mechanism of injury and injury patterns found in the geriatric patient. Injuries from falls, motor vehicle collisions, and burns tend to be the leading causes of traumatic death in geriatric patients given physiological changes in how the body responds to trauma. It is also a sad reality that elder abuse occurs routinely within our society. Elder abuse and neglect can encompass physical, psychological, and financial mechanisms. Caregivers and children are commonly the abusing parties, and EMS personnel are required to report this type of abuse and neglect as well. Thorough assessments and good history taking are essential in recognizing potential elder abuse and neglect. Traumatic injuries due to falls are common in the elderly population for numerous reasons. As we age, sensory impairment becomes more pronounced. Eye movement and pupillary reactions slow with age while the eye's peripheral field narrows. The lens of the eye changes by thickening and losing opaqueness, making it more difficult to focus on objects. Progressive hearing loss is also common. These sensory changes make ground-level falls much more common. The brain also atrophies over time, meaning that it physically shrinks, losing approximately 20% of its size by the time a person reaches the age of 89. While the brain itself shrinks, the skull does not. As a result, the brain no longer sits snugly within the skull, and sudden movements of the head can lead to significant brain injuries as the brain moves around and strikes the hard, bony interior of the skull. Given this movement, blood vessels are likely to stretch and break, resulting in significant bleeding into the void space that was once occupied by a much larger brain. Even a somewhat innocuous ground-level fall can result in a subdural hematoma within the geriatric population. Other diseases impacting the brain can impact the geriatric patient's equilibrium, resulting in a loss of balance. The responsiveness of our peripheral nervous system slows with time, which causes changes in our neurological, sensory, and motor routes. Given decreased sensation and slower reflexes in the geriatric patient, traumatic injury is more common in the elderly. Musculoskeletal system changes within the geriatric person also increase injuries due to falls. Muscle mass decreases over time and is commonly replaced with fat. Muscle fibers become smaller and fewer, resulting in an overall decrease in strength. Reduced muscle mass coupled with atrophy of supporting structures also produce postural changes in the geriatric patient. One of the most common changes observed is kyphosis, otherwise known as a hunchback. A patient with kyphosis has shoulders that have moved both anterior and medial, the head and neck move anterior, and the upper thoracic spine becomes more pronounced. It is important to keep these changes in mind when preparing a geriatric patient with kyphosis for transport to the hospital. Beyond those changes, ligaments lose elasticity and cartilage degenerates, with arthritis being the result. Bones lose density and strength, so pathologic fractures become more frequent, especially in postmenopausal women. Hip fractures and vertebral body collapse are also common in the older population. Falls can also be indicative of more serious problems occurring in different body systems. Abnormal electrical disturbances in the heart can result in syncopal episodes in which a ground-level fall and resultant injuries are secondary to a much more serious cardiac rhythm problem. The likelihood of medication issues also increase with age as geriatric patients develop pathologies requiring pharmaceutical intervention. Some medications can produce side effects that may alter a patient's mental status, affect stability and sensation, or have a profound impact on the body's ability to compensate for traumatic injuries. As a part of the healthcare system, EMS providers have a responsibility to provide public information and education while also participating in injury and disease prevention activities. One such area of preventative focus is that of geriatric fall prevention. It is important for elderly patients to have their medications reviewed regularly to ensure correct dosages without significant side effects if possible. It is also important for the elderly patient to take his or her medications as prescribed. Supporting a medication routine while ensuring geriatric-friendly storage of prescribed medications, some elderly patients are unable to open child-proof medication containers, can have a very positive influence on the geriatric patient struggling to maintain a pharmacology routine. On the other hand, it is also important to ensure geriatric patients with cognitive defects are not taking too many medications at one time. Poor sensory perception can result in falls, which means it is important for the geriatric population to receive necessary eye and hearing care. Eyeglasses and hearing aids should be prescribed to and used by geriatric patients with those respective sensory deficiencies. Encouraging the use of walkers or canes, eliminating tripping hazards and other obstacles such as throw rugs or unnecessary furniture, installing handrails, and adjusting the temperature on water heaters can all help reduce the likelihood of serious injury within the geriatric population. Exercising, including strength and flexibility training, is important for all age groups, but it is even more important for the older population. It is important to fight the effects of age by exercising to maintain adequate muscle mass, bone density, flexibility, and stamina. An increasing body of research shows that the brain needs exercise as well. Encouraging intellectual pursuits within the geriatric community is also important. The intent of this module was to provide an overview of trauma. Additional information regarding traumatic injuries will be shared in other modules within this course. With this module now completed, you should be able to define kinematics of trauma, discuss various traumatic injury patterns and their predictability, discuss specific injuries related to multisystem trauma, discuss identification and categorization of trauma patients, discuss the golden hour period, describe key components of the trauma patient assessment, list significant mechanisms of injury, discuss trauma scoring, discuss management of the trauma patient, differentiate between injury patterns seen in adults and pediatrics, describe the injury patterns and causes of trauma in geriatric patients, discuss risk factors that make geriatric patients prone to injuries due to falls, explain the importance of fall prevention in geriatric patients, and appreciate the importance of recognizing significant mechanisms of injury early in the assessment process. This presentation was created by Waukesha County Technical College with grant funding from the Wisconsin Technical College System.